Assessment of the respiratory system.
Inspection. The chest should appear slightly convex, no sternal depressions, intercostal spaces should be flat or depressed, there should be no thoracic abnormalities, the chest should be symmetrical when breathing, skin should not be dry and uneven in colour. Defining the respiratory rate. To find the respiratory rate, count how many breaths a patient takes per minute, or count the amount of breaths they take for 30 seconds and times it by 2. The normal amount of breaths per minute are between 12 and 20. Interview. When interviewing a patient, it is important to plan communication. Be sure to obtain a medical and social history when interviewing. Make sure you are working as a partnership with your patient and that the patient's family feels that they are equally participating. Make sure you leave enough time for the interview. Palpitation. When finding palpitation, you are feeling for any parts of the skin that may be tender due to chest wall injury from fall or trauma. There are advanced palpitation techniques such as palpitation of the trachea. This is used to find that the trachea is central and equally distant from each clavicle. Palpitation of the trachea can be used to find signs of chest trauma that could be potentially life-threatening. Measurement of respiratory execution is done by using your hands on the patient's posterior thorax at the 10th rib while placing both thumbs almost touching the vertebrae. Ask the patient to take a few deep breaths while noting the movement of your hands. Your thumbs should move about 5 to 8 centimeters symmetrically at maximal inspiration. Tractile thermitis is the capacity to feel the sound on the chest wall. This is assessed by putting your palms on the patient's chest wall. Be sure to avoid bony areas. Ask the patient to say 99. Notice the vibrations beneath your palms. Vibrations should be equal. Percussion is a specialist skill that aims to find tissue that may be filled with air, fluid, or a solid material. Normally, percussion is formed on the posterior chest with the patient pulling their shoulders forward. The patient's back is examined to find any difference on either side of the back. The intensity and quality of the sound is noted. Auscultation. Chest auscultation can be done by nurses, midwives, and other clinicals to listen to airflow. Chest auscultation is found using the diaphragm of a stethoscope. Normal sounds include vascular sounds. These are low-pitched sounds, soft-sounded, that are heard during expiration and heard over most parts of the lungs. Bronchial sounds. These sounds are high-pitched and longer sounds heard over the trachea. Bronchovascular sounds are medium-pitched and medium sounds during expiration. These can be heard from the upper part of the chest area. If abnormal sounds are heard, ask the patient to cough and listen for a few breaths. Record if noise persists. Abnormal or adventitious sounds include crackles. These are discontinued sounds that happen when air moves through airways that contain fluid. Crackles can further be classified as fine, medium, or coarse. Fine crackles are high-pitched sounds that sound like static, which normally are heard at the end of inspiration or early expiration. Medium crackles are louder and may sound moist. Coarse crackles are louder than medium crackles and sort of sound bubbly during inspiration and expiration. These cannot be cleared by coughing. Often they are found at the base of the lungs and often seen in patients with pneumonia. Wheezing can be heard during expiration or inspiration. It is caused by airways being constricted, possibly by swelling, secretion, and tumours. Often wheezing is heard by asthmatics or people with COPD. Pleural friction rub is constant dry and grating sound made by inflammation of pleural surfaces. More often it is heard during inspiration but can sometimes be heard during expiration. Often this noise is heard in patients with infective pericarditis.
Created using Powtoon.